Now, we've heard about a number of potential side effects, adverse effects of using PEEP or using lung recruitment techniques. And one potential side effect, which has not been mentioned so far, is the risk of influencing brain perfusion, which of course would be particularly important in patients with brain injury. And Dr. Thomas Bein from Regensburg in Germany is going to talk to us now about lung recruitment manoeuvres in patients with cerebral injury. Does it provide benefit or can it harm them?
Mr. Chairman, thank you very much. And the Siemens management, thank you very much for the invitation. Lung recruitment maneuvers are very common, not only in anesthesia, but even in intensive care medicine. Since in intensive care medicine we have problems with alveolar collapse too. And in the moment there's proposed lung recruitment maneuver with peak pressures up to 60 centimeters of water, according to the recommendations of Dr. Böhm and Professor Lachmann. And since we have often problems of the combination with brain injury and acute lung injury, patients with acute traumatic or not traumatic brain injury often present with acute lung injury due to aspiration of gastrointestinal contents or pneumonia or the so-called neurogenic edema. And the incidence of this combination ranged from 20% up to 50% in patients with severe brain injury or multi-trauma. And we wanted to know whether a lung recruitment maneuver in these patients might deteriorate cerebral perfusion or cerebral hemodynamic. The intensivist has to treat as a primary goal, has to prevent or treat cerebral ischemia as well as manage acute lung injury, and that might be a topic of conflicting interests. The primary goal in the treatment of acute cerebral injury is to maintain a high cerebral perfusion pressure, to control ventilation. In some cases or situations, it might be necessary to make hyperventilation in acute crisis of intracranial hypertension, and to give adequate volume replacement. On the other hand, in the management of acute lung injury, we want to apply a high PEEP to prevent alveolar collapse, and actually we have to follow the results of the ARDS network study, and we have to use lung protective strategy, which allows a permissive hypercapnia. And you can see that there may be some conflict of interest between these two therapeutic strategies. The application of high PEEP in patients with acute brain injury is an issue of controversy, and as you see, not much data in the last years. We have some investigations with different results which we cannot interpret correctly. Some investigators found no change in the variation of PEEP between 5 and 10. McGuire applied a PEEP of 15, and in some patients he found a deterioration or an increase in intracranial pressure. And from the internal medicine in stroke patients, they, I guess, had very low levels of PEEP, which are a maximum of 12, which is not actually discussed in lung protective strategy. So we performed a study in 11 patients with acute lung injury. Glasgow Coma scale indicated moderate to severe acute brain injury of traumatic and non-traumatic origin. 5 patients suffered from brain injury and the other patients from subarachnoid hemorrhage or infarction. And all patients had the presence of acute lung injury according to the consensus conference, reduced oxygenation index. And we ventilated the patients in a pressure control mode and set the PEEP, moderate PEEP, between 8 and 10. The patients had adequate volume replacement. Central venous pressure was around 8. We then applied an open lung maneuver according to the recommendations of Lachmann. We set the PEEP between 8 and 10 and didn't change that PEEP. This was a modification of that concept. And we made a stepwise increment of the peak pressure until up to 60 centimeters of water. This is a very high peak pressure. We decided to use such a high peak pressure because we wanted, after this maneuver, we wanted to go back to the same level of very low PEEP. And we did not want to change the PEEP following the maneuver. The time span of this maneuver was 30 seconds for the stepwise increment and 30 seconds for the plateau of 60 centimeters of water. And after this maneuver, all the ventilator settings were set back to the previous condition. The neuromonitoring was performed by intracranial measurement. All patients had received intraparenchymatized sonde for ICP measurements. And one very important variable is the cerebral perfusion pressure, which is a result of mean arterial pressure minus ICP. And all patients had received retrograde cannulation of the jugular bulb via the internal jugular vein. You know that collecting the blood from the jugular bulb allows the estimation of jugular bulb oxygenation, and that is a good bedside measurement of cerebral blood flow. And you can measure some variables of cerebral metabolism, like the arterial jugular venous lactate content difference, which gives some information on the presence of cerebral ischemia. The results: first, oxygenation. At the end of the open lung maneuver, at the end of this minute, we found a significant and impressive increase in arterial oxygenation. That's what we expected. But surprisingly, 5 minutes, 10 minutes and 30 minutes, we repeated our measurements. And after 10 minutes, the effect on the oxygenation was gone and disappeared. And the oxygenation ratio was the same as before the measurement. But I have to, it's important to say that we didn't change the PEEP after this open lung maneuver. And for me, the more interesting results are that during the maneuver, at the end of this minute, we found a significant and impressive decrease in mean arterial pressure and simultaneously a significant increase in intracranial pressure, which you can imagine results in a heavy drop and decrease of cranial perfusion pressure. And the red line indicates the threshold where we believe that cerebral ischemia begins. And before the maneuver, the cerebral perfusion pressure was in a region where we have no cerebral ischemia, but during this maneuver we found a heavy decrease which might induce cerebral ischemia. But after 10 and 30 minutes, all the results were within the normal range again. And additionally, we found concomitant decrease in jugular bulb saturation, indicating a critical situation for the brain during this open lung maneuver. The arterial minus jugular venous lactate content difference tended to be increased during or at the end of the maneuver and 10 or 30 minutes later, but the standard deviation was very great, and we could not we can interpret it as a trend, but it's not a statistical relevant difference between the values. So, what is for me the conclusion? We have the problem in patients with acute lung injury and acute brain injury to keep the lung open and to prevent alveolar collapse. Open lung maneuver, which we applied with very high peak pressures, up to 60 centimeters of water, might alter cerebral hemodynamics and cerebral metabolism. So I would not recommend this maneuver, repetitive maneuver, for instance, in 5 or 6 times a day. But the question is, do we have other methods of lung recruitment with lower peak pressures for another time span, which may not deteriorate cerebral metabolism? This is the first question. It's not answered yet. And I believe the second question is the story of PEEP and cerebral injury should be renewed with new studies, including not only the intracerebral pressure, but even mechanisms or methods like jugular bulb oximetry and some other methods for measuring cerebral metabolism. But for me, we do not use this maneuver in that heavy method up to 60 centimeters again in our ICU. Thank you very much for your attention.
Thank you, Dr. Bein. Any questions? Yes.
The way, Guggenberg from Tübingen, also Germany, the way you performed this lung opening maneuver caused a very high pressure gradient above the lung, so you would get very high tidal volumes, I guess, because the original Blachman maneuver is designed to avoid high tidal volumes. And there have been studies which show that a huge distension of the lung causes liberation of some vasoactive agents. You can call them TNF-alpha, and this type of agents are discussed. May this be the case in your study, that cerebral hemodynamics are altered by some way of hemodynamics which are liberated outside the brain?
The influence of vasoactive mediators or some other kinds of mediators during this maneuver may be maybe have some additional effects, but I personally believe that the effect on the brain is the combination of an increase in intracranial pressure and the decrease in mean arterial pressure, and that, I believe, is much enough to decrease cerebral perfusion pressure in a way we don't want to have it. And the result is a short but impressive deterioration of cerebral hemodynamics.
May I ask a first question? With respect to cerebral hemodynamics, what Guggenberg once again, sorry. With respect to cerebral hemodynamics, I think that your results quite clearly shows a decrease in cerebral perfusion pressure. But within 10 minutes, your results also show that the perfusion pressure is back to normal. And what we fear most in neurosurgical intensive care units is not a high peak intracranial pressure, but a long-lasting high plateau of pressure which doesn't go back to normal within some minutes. And your data clearly shows that the cerebral perfusion pressure is back within minutes, I guess, as far as I can conclude from your data, because the first point was 10 minutes. And I think that's quite encouraging. I think it's not so much dangerous.
If we try to maintain, in an acute brain injury, if we try to maintain an adequate cerebral perfusion, then a heavy decrease for 1 minute might be enough to make a short deterioration. That's what I can say. And we made a single open lung maneuver. And you see, on the oxygenation, we had no long effect. So if you don't have the data concerning the cerebral metabolism, then you might be invited to repeat this open lung maneuver after 10 minutes or after 30 minutes or after 1 hour. And I think without this data, or with other words, with this data, I think you should be carefully or the discussion of the application of such open lung maneuvers in neurosurgical patients should be extended, and we have no clear recommendations what we can do with these patients.
I think what was interesting about your results, one of the things that was interesting about your results was, although there was no statistically significant change in the lactate, venous lactate concentration, it did appear to be tending to increase and to be increasing at 10 minutes later. I think it was 10 minutes later as well.
Yeah.
And also I noticed that there was considerably more variability in the jugular venous oxygen saturation after the open lung manoeuvre than there had been before. So perhaps there were some effects even from this short open lung manoeuvre. Question down here.
Yes, Jyrki Tenhonen from Kuopio, Finland. I think this is a particular group of patients with quite large problems when concerning two sides of the treatment. Now, I have a question. How would you find in the future, in this group of patients, not to recruit lung in short period of time, but rather control the PEEP level, increasing PEEP gradually, and also controlling the let's say static higher pressure of inspiratory high pressure, or increasing mean airway pressure, like controllably in time, and see the results?
That's what we try to find out in the moment with our monitoring of intracranial pressure measurement and jugular bulb cannulation. We try to vary PEEP in the moment, 5, 10, 15. And in some patients we have the impression that this is the beginning of a new study. And because there are no data with discussing the PEEP story in neurosurgical patients with using variables of cerebral metabolism, like cannulation of the jugular bulb, or you can make microdialysis or something like that. There are no data. And we try to find out. And what we have seen in 2 or 3 patients is in a PEEP with 15 for half an hour or longer, you find a begin of an increase in arterial minus jugular venous lactate difference, and a deterioration of the oxygen saturation, bulb oxygen saturation, not as heavy as in the maneuver, but slightly decreasing with a PEEP of 15. But I think this has to be elucidated in some studies.
Thank you very much. I think we must move on. There will be an opportunity to ask questions later on.